general virology. You guys can see that small font in the back. Talked about viral exteriors, little cartoon in the upper right to help you along with that question. We're talking about, like, hypothetically, we're talking about an enteric virus. What would be the characteristics that would need in order to survive that trip? Capsid exterior, yeah. All right, good. Here's a kind of a harder question. We didn't really talk about too much, but let's see how we do. We have a nucleoside analog, which means it resembles a nucleoside. An antiviral is a nucleoside analog, which many are. Which step in the infection cycle would be targeted, do you think? Why replication and not something like uncoding or another step? Okay, yeah, when it's time for the virus to actually make copies of its genome and to replicate its genome, it's going to need nucleic acids, it's going to need nucleosides, right? So if you have something that works as a nucleoside analog, it's going to disrupt that step specifically. And there, like I said, there are drugs that do that. They tend to be broader spectrum antivirals, like ribavirin. That would appear here. Okay, let's try this one. Talk about mutation rates. If you have a viral genome, which one is associated with higher mutation rate? RNA, good, okay. Genome replication for RNA viruses, almost always with the exception of one virus, occurs either in the cytoplasm or nucleus. Which one? Cytoplasm. And the exception is influenza. An RNA virus, it has to go into the nucleus. Which type of viral infection occurs in permissive susceptible cells that does not result in the production of progeny viruses? We talked about these 4 different categories: lytic infections, persistent infections, latent infections, or abortive infections. Which do you think that sounds most like if the cells are susceptible? Yeah, here's some people saying latent. Why do you think it's latent infection?
Because it's susceptible. It's not producing. It's like it's waiting till those changes in time.
Yeah, so it is susceptible. If it were non-susceptible, then what category would it be? If you're not producing any progeny virions. It would be abortive. Then there would be no viable virions produced from that cell. But since it's susceptible and you're not getting copies of the virus, that would be a latent infection. And then persistent would be like what type of scenario we're talking about with persistent viral infection. Yes. Like what? HIV does have latent phase, yeah. So do the herpes viruses that we're talking about today. But yeah, so you're producing low levels of virus, usually not enough to like draw and attract a lot of immune attention, but enough where you can sustain that viral infection. Yep, good. Okay, a couple questions about influenza specifically. We've got that mock-up of the like basic influenza virus structure. Let's see how we do here. Is it enveloped or non-enveloped? Enveloped or capsid, in other words. That is not correct. Okay, so it's an enveloped virus, as many RNA viruses are. That cartoon is showing this lipid bilayer envelope that it gets from the host cell. And it's a respiratory virus, so that makes sense, right? It's going to be protected in those droplets, or slush droplets, so maintain that moist environment. It does not linger out in the environment for a terribly long time. In terms of its genome, we've got a bunch of options here. We've got a couple flavors of DNA, either double-stranded or single-stranded DNA. So first of all, is it a DNA virus or an RNA virus? It's an RNA virus, so let's eliminate the DNA options. Look at the RNA options. It could be double-stranded RNA, but isn't? No. So it's either single-stranded or, I'm sorry, it's either positive sense or negative sense RNA. Which do you think it is? It's negative sense. Very good. And then lastly, the genome. Is it segmented or non-segmented? It is segmented. A lot of viruses are unsegmented, this one is segmented, and that has implications for what thing that we talked about extensively last week. Genetic diversity, reassortment, exactly, so there's shuffling of the deck, these different segments can be shuffled when you have co-infections with different virus strains in the same infected cell. Talking about, now look back at the cartoon, we talked about some membrane proteins on influenza that are really, really important for epidemiological purposes and a lot of other facets of influenza virology. What are the two main ones that we talked about that we use when we subtype influenza A? Hemagglutinin, or H, yeah, and the other one, what was the other one? Neuraminidase, yeah, good. And in terms of functionality, what does hemagglutinin do for influenza? Yeah, it's the glycoprotein that binds to its host cell receptor, which is what? Sialic acid, very good. And then neuraminidase, what's its function of the virus? Yeah, it cleaves that as the virus is trying to escape or release from that host cell when it's done. It's still tethered, right? It's tethered to that sialic acid via its hemagglutinin, very high affinity bond between those two. So that neuraminidase function is to keep that tethered and allow that virus particle to be released so it can infect new cells. We already answered this one, we said sialic acid. 4 types of influenza virus, and which one has the greatest pandemic potential? A through D, and the one with pandemic potential is A, very good. And then the influenza A subtypes that are included in that 2024-2025 vaccine, and actually are included in most recent vaccine formulations. What do you think? H3N2, close. And bonus point, H1N1 is the other one. And this one we already answered, what happens during viral reassortment. So again, just imagine 2 virus particles, 16 segments reassorting after anything less. As a bit of a review question, you may have seen this before, maybe back in exam 1, block 1. Let's go over this one, just because we were talking about the infectious cycle. Remember this question, which of the following best characterizes the eclipse phase of a viral infection? Most of you got this one right, but just as review now, I put the figure that we used to talk about this topic up here. What about option A, a period where the host immune system effectively eliminates the virus? No, that would be more like which side of this curve do you think? When you're starting to get decrease of those virus particles because the immune system is clearing them out, that would describe that aspect. What about option B, the phase where the virus is actively spreading from cell to cell? Not really, right? Because you're talking about, I mean, this happens at greatest magnitude during the exponential phase here, right? Exponential phase, and the eclipse phase here. So that's not accurate. What about a period of rapid viral replication within host cells leading to cell lysis? What do you think about that statement? Do all viral infections result in lysis of the host cell? No. We talked about budding and the ability for some cells to survive and withstand a lot of that. So that is a little bit too specific for it to be a general true statement. The rapid viral replication, some of them, and rapid compared to what? Some of them are slower than others. So yeah, I mean, viral replication might take place in the eclipse phase, but this is too specific and not the best choice. Now, letter D, the period of initial attachment of the virus to receptors in the host cell membrane. What do you guys think about that? Would you? Okay, so let's say you've got, I like that, double down. Okay, so let's say you've got a virus particle like influenza that's attached to, its hemagglutinin has made that initial attachment to sialic acid residues, and that's all it's done, it's just hanging on the surface, that's all that's happened, because that's what this is it's just attaching to the receptor on the host cell membrane. Are you gonna get a productive infection? Doesn't it have to enter, uncode, replicate, translate its proteins, assemble, and then get released? So that's not the Eclipse phase, is it?
Was this the exact question?
This is the exact question.
I don't remember that.
It is, guys. Scout's honor, I would not mess with you on this. Nope. No, this is it. And I know when I read this, I was like, I'm sure I didn't miss you that. And that is exactly what it says. Now, let's look at option E. What does option E say?
Says yes.
Exactly. So we've got new genomes being made, we have viral proteins being made, but because that hasn't been assembled and released yet, the final product isn't off shelf. You could stop everything right up to this final point and you would have no productive infection. And that is indeed how some antivirals work. They target that very last step in the infection. That's how they work. So everything up to that point has been done, like you've already made all those viral molecules. And you simply interfere with that very last step. What would be an example of an anti-influenza drug that would interfere with that last release step? Tamiflu, oseltamivir, or drugs like peramivir. Yeah. Okay, so moving on from that point then. Here's another slide previously on some anti-influenza drugs. We talked a little bit about how amantadine and neuraminidine are no longer really used anymore because of high levels of resistance in circulating influenza strains. It's kind of a shame because that's an entire class of antivirals. Meloxivir is still used. That specifically targets the RDRP of influenza viruses. If you were to try and use it, if you were to just diagnose empirically somebody who had some respiratory symptoms and you thought it was a viral etiology, you tried to use a drug like Meloxivir, do you think it would work? No, because it's specific for that virus's polymerase, RDRP. So there's specificity there. That's one of the reasons why you would make an argument for diagnosing for that and getting confirmation that this is what the patient has before you treat something specific like this. And then finally, this class, they're neuraminidase inhibitors. So this cartoon is just showing you what happens normally where these viruses are released from host cells because they have functional neuraminidase. And then when you have a neuraminidase inhibitor, like oseltamivir, Tamiflu, which will bind to neuraminidase, not the hemagglutinin, so it's still tethered by hemagglutinin, but the neuraminidase, and then it can no longer cleave off. So that's release. Okay, so that should hopefully summarize influenza. Now we can move on to talking about some common cold viruses. In terms of the feasibility of ever developing either vaccines against all common cold viruses or treatments against them, what do you guys think the likelihood is of doing that? Probably not. Yeah, not feasible. We could blow through our entire budget for research and development and probably still not be able to succeed in that goal. Because in every one of these viral families, there are a number of different serotypes. We get reinfections commonly throughout life. And generally, this is not a disease that's associated with high mortality. So maybe some morbidity, maybe some suffering, and that's unfortunate, but it's just part of life, right? You deal with it. So because of that, a lot of these common cold viruses, we don't have specific antivirals for. Most of these are going to be treated with common drugs, that just over-the-counter drugs that relieve symptoms, but not specific antivirals. This pie chart doesn't jive 100% with this, but more or less, one of the truisms is that rhinoviruses are one of the most common causes of common colds. Rhinoviruses are capsid viruses, so they're the hardier exterior positive sense viruses. A bunch of different serotypes there. They're responsible or associated with like a lot of runny nose types of symptoms, upper respiratory tract infections. We do get reinfections throughout life. Coronaviruses, we usually just think of SARS-CoV-2, which we'll talk about also. But there's like 4 to 7 circulating common cold coronaviruses as well out there. Those all have positive sense RNA genomes, they're enveloped, and they contribute a lot to the common cold presentation as well. Adenovirus adenoviruses, lots of serotypes for adenoviruses. They have a pretty big tropism for different cell types, and for that reason, as we'll see, their symptoms can range, and their types of presentation can range as well. So more than just a common cold virus, it can do some other things as well. And then finally, RSV. This is an important one because mostly because of the pediatric population. That's what it's known for. It affects a lot of infants and very, very young children. Just in terms of generalities, talked about transmission a little bit. A lot of transmission occurs through coughing and sneezing on people, but you want to make sure that you understand, especially since you will be interacting with patients, that you know the transmission can also occur through the eyes. We briefly mentioned that, right? But not just coughing for someone's eyes, but somebody touching their own eyes with their fingers or their hands. Studies have been done that show that we touch our face multiple times, and we tend to touch our face more when we're talking and interacting with people. So it's not something that's likely, we can tell people to stop touching their face, but that's probably not realistic. And that'll probably be something that continues to contribute a lot to transmission of this. In terms of symptoms, you're probably all familiar with like sneezing and the runny nose and stuffiness. A lot of that is due to immunopathology, where you get these viruses that start replicating in whatever host tissue in the upper respiratory tract they infect. And then those infected cells, as they're infected, will start releasing cytokines like IL-1, IL-6, IL-8, tumor necrosis factor alpha. That will attract neutrophils. You'll get some swelling. You'll get some leaky vessels. You will get stimulation of mucus in goblet cells and nasal mucosa. So all of those contribute to that pathology that's associated with these common colds. Symptoms usually peak a couple days after onset, and then they last for anywhere between 7 to 10 days. Sometimes they can go a little bit longer than that. But the point is, they're not going to be chronic infections. They should resolve. And they oftentimes resolve sooner than bacterial respiratory infections. Another important point here is that you're contagious during the entire symptomatic period, oftentimes before you even have onset of symptoms. Have you ever been around someone who is sneezing and coughing and says something like, "Don't worry, I'm not contagious anymore"? They do not know what they're talking about when they say that. There's no way of knowing that, and they're wrong anyway. So they probably are still shedding virus at that point. In terms of lab diagnosis, when people have common cold symptoms, they should, most of the time, they do not need to seek diagnosis, and the lab doesn't generally run these unless it's a high-risk patient population. If it's a child and RSV is going around, that might be one of those exceptions because there's some really severe infections in kids, or older patients, immunocompromised patients, things like that. For RSV, we do have a rapid test. There's an image of that in another slide, so we can diagnose that. A few considerations here. Some antivirals, and I had mentioned this before with influenza specifically. We do have specific drugs for influenza, so that's great, and it's especially great if you can administer that within 48 hours of exposure, not symptom onset, but exposure, which is really tricky, right? It takes a while for you to get symptoms. But if you have a common cold and you want to prescribe one of those specific anti-influenza drugs, that is not going to resolve symptoms. It's not going to help because it's not targeting specifically that virus. Ditto with antibiotics, obviously, the more obvious, right? If you just give somebody who's presenting with respiratory symptoms some antibiotic, not a good idea. Most of these etiologies are viral, so antibiotics can do anything for that. With RSV, again, infants, high-risk children, they do get hospitalized, they do need oxygen therapy. So we take that a little bit more seriously in ordering those tests. Plus, those tests are pretty rapid and inexpensive tests. We have, those immunoassays and respiratory panels as well. And then also keeping in mind that secondary bacterial infections are another consideration with common cold viruses. Oftentimes they come out on the flanks when you're recovering from a cold, or you're more susceptible to these secondary bacterial infections. In terms of severity and duration, rhinoviruses do tend to have milder and shorter colds associated with them. With adenoviruses, those can be a little bit longer. Also conjunctivitis, and there's some other symptoms associated with adenovirus too that are unusual. And then with coronavirus, there are, as I said, 4 to 7 different species, if you will, of coronaviruses, just common cold coronaviruses. They are associated with different types of severity and different durations. With RSV, the reason why we are so concerned about the pediatric population is one, just looking at the numbers here, the number of hospitalized children, 100,000 US. The reason being is this particular virus is associated with causing bronchiolitis, which is, when your bronchioles start getting inflamed. With adults, we have a pretty wide diameter for our bronchioles, so we can support a little bit of inflammation without it compromising our ability to breathe. But with children, they have teeny tiny little bronchioles, so when they get inflamed, that causes problems for them to breathe, potentially fatal problems. So there are deaths in the pediatric population due to RSV, but the major population that gets killed is the elderly population. Up to 10,000 people a year, most of those are elderly folks. This too, repeat infections are very common. You can easily get RSV as an adult. There's an RSV-A and an RSV-B. I think RSV-A is slightly more severe for adults, but generally those symptoms are pretty minor in adults because you do have some previous immunity. There's a picture of that BinaxNOW rapid antigen test in the lower right. And this is also one of many targets on this multiplex respiratory PCR panels. You guys ever seen the respiratory panel BioFire? It has all the parainfluenza viruses on it. It has RSV on it. It has influenza A, influenza B. And metapneumovirus, a lot of these viruses that we're talking about are on that one panel. We have some passive therapies, some monoclonal antibodies for infants that can get them by for 1 season or so, just until they start developing their own immunity, so these infections aren't so severe. And then we also have a couple vaccines for older adults that are licensed for those 65 and up, like Abrixvi and Abrextro, I think is the other one. And we have the parainfluenza viruses. These are nascent enveloped viruses. There are 4 of them. They do have varying severities, and not a lot really to say about this. I did my master's thesis on HPIV3. I can tell you it's a pretty boring virus. There's not much to it. There's a little bit of seasonality associated with the parainfluenza viruses that is notable, particularly HPIV3. That's the one that's unusual because it peaks in spring, early summer, and PIV1 and 2 are more like towards autumn and fall. In terms of the symptomology, croup is up here on one of the associated infections with these viruses. You guys know what croup is? Barking cough, stridor, yeah. So an infection of larynx and trachea. Generally a little bit more severe, especially in kids. Any extroverts in the crowd here? Nope, not one. Okay. Okay, I was gonna see if there was a volunteer who could do a seal impression. Okay, fair. Okay, I'm certainly not that extroverted, so I'm not gonna do a seal impression for you. But that.
I can do one.
Will you? Okay. That is so, no, that's not what I was talking about.
Detail. Detail.
Oh my god. Okay, next time. But thank you for that, I'll take that.
That's probably why I have a beating in class.
Yes. Okay, so what croup sounds like, in addition to that like sharp barking cough, is a seal bark. I really want to do it for you, but I just can't.
Do it. Do it.
No, man, I'm already having
Close your eyes.
Oh my god, no, I'm already having a day, so I'm not gonna do
What
it.
kind of a day are you having? You celebrating anything?
God, no.
Alright.
Okay, yeah, super socially awkward day. So So yes, this too is a target on that PCR panel with specific treatments or vaccines for the parainfluenza viruses, boring viruses. But if I could give you a couple takeaways when you're studying for the exam, know the seasonality of these and know that they can cause croup. That's an important one. Similar with metapneumoviruses. If you've never heard of metapneumoviruses, it's unusual that we've only known about them really for the last 20 years or so, but they shoulder a lot of that infectious disease common cold pie chart. They circulate a lot. They don't really have that age tropism that we were talking about with like RSV. So adults are just as likely to get this, probably won't get much immunity. They do tend to be milder infections. But note, this too can cause some more serious lower respiratory tract infections like bronchiolitis, which tends to be a little bit more severe than bronchitis. You know, you guys in AP, I know you were starting on respiratory. Are you done with that system now?
We're in it right now, man, we test on Friday.
Oh, okay. Okay, so where would you put your level of expertise on the respiratory tract right now?
2 out of 10.
Okay,
2 out of 10.
okay. That was fast.
There's 2 months.
Okay. Alright, so bronchiolitis, infection of the bronchioles, pneumonia, strictly speaking, what's the technical definition of pneumonia? What's infected, what's inflamed? Just the lungs itself, like the parenchyma of the lungs, that the air sacs are infected and inflamed. So that can be really serious, that can be deadly. Okay. Yes, it is indeed, yes. What else? That's about all. So yeah, a lot of common features to these, none of them have specific treatments, with the exception of RSV. Transmission is the same, diagnostics is the same, and usually not done. Then we finally come across something new and a little different with adenoviruses. First striking thing about adenoviruses is the fact that they're not RNA viruses. This is the only DNA virus on this list of respiratory pathogens that we're talking about. It's also a capsid virus, non-enveloped capsid virus. So that has implications for transmission and its ability to survive a little bit longer. Many different antigenic types of adenoviruses. That complicates our efforts to design vaccines, and this is one that we have considered heavily for vaccine development because it's such a nuisance. And then in terms of the diseases it causes, I mentioned that it causes more than just common cold symptoms. We've got our normal common cold stuff with pharyngitis on that list as well. Atypical pneumonias, which we've talked about before, cold-like symptoms, and then we've got ARDS, which is a really serious respiratory problem that can be potentially fatal. Conjunctivitis, it's viral pink eye, it's a very common cause of viral pink eye. So you have to rule out bacterial etiologies if somebody's presenting with conjunctivitis like that. Cystitis, what is that? Bladder, so nowhere near the respiratory tract, right? But with some of these serotypes of adenovirus, some of its receptors are on bladder cells, so you get bladder infections. Similarly with GI disease, you can get some pretty severe diarrheal diseases associated with certain serotypes of adenovirus because of that. For us, we I guess are a lucky population. We have a vaccine for adenovirus, at least 2 serotypes, 4 and 7. And that is because we tend to have these we have a rigorous lifestyle and in close proximity to each other. We've had some really big outbreaks of adenovirus in military populations, and that has compelled the DoD to put funding and effort into actually reintroducing this vaccine. We had it in wide use in the 70s and 80s, and then we pulled it, and then we had to bring it back for military populations. A large part of the impetus for that was an outbreak in Lapland with Air Force trainees, where a large number of this cohort of trainees got sick with adenovirus and developed some really severe respiratory symptoms. So thank the Air Force for providing that motivation to develop this vaccine that's military specific. We're the only ones to get it. It would be problematic for the general population because of the fact that this is a live virus vaccine. So when you're inoculated, when you're vaccinated with this vaccine, you do shed this virus like in your stool, for example. And that's generally not considered to be a great trait for a vaccine. So we keep it, the population that it's targeted to, really small, restricted military population. All right, to kind of summarize these respiratory viruses, this is a slide that has some of the associations with seasonality, so you can start predicting what time of year corresponds to different viruses, the likelihood of these different viruses. Kind of take it with a grain of salt. Notice the PIVs, they have sort of that unusual seasonality, but in the winter months, this is when we get most of these respiratory viruses circulating. And that's more due to just behavioral reasons, people crowding indoors more than being outside. This association with enterovirus D68, which we'll actually talk about later in this deck, being in even numbered years, I have no idea what the explanation is for that. I'm still searching for one, but what year is it right now? I guess we're in an off year for that. Which of the following viruses is associated with even numbered year outbreaks? Okay, so we'll spend a little time talking about coronavirus, COVID-2 specifically. We talked about some of the common cold coronaviruses. There's also some big ones besides coronavirus 2 that are associated with big epidemics. You guys remember MERS? Yeah, Middle Eastern Respiratory Syndrome. So that was circulating, it's still circulating actually, just in really small numbers and geographically restricted mostly to the Middle East. But yeah, that was a pretty bad outbreak of a related virus, it was a coronavirus like this. And then anybody old enough to remember SARS-1? Yeah, early 2000s. That had fairly high mortality rates as well. That is no longer circulating in the human population. That's gone out of circulation. But we still have this one, and who knows how long this will be circulating in the human population. Really interesting. Just in terms of formalities, making sure that you understand the distinction between the disease that this virus causes, which is COVID, coronavirus disease, and the actual etiology of the virus that causes it. Severe acute respiratory syndrome, coronavirus 2, that's the distinction there. Same transmission patterns, including that inoculation of mucosal in the face, and the mouth, nose, eyes. It is an enveloped virus, positive sense envelope virus, but it is able to survive outside depending on, things like UV, air circulation, temperature, humidity, up to a few days. Incubation period is kind of on the lengthy side on average for people relative to these other common cold viruses. With the number of people that this virus has gone through on the order of hundreds of millions, there's a lot of variability. So some of those incubation periods are as short as 2 days, others are as long as 2 weeks. It's just a lot, but on average 5 to 6 day incubation period. And then the symptoms during the acute infection can last anywhere to 5 days to 20, and sometimes beyond 20 days. The symptoms include typically fever, cough, shortness of breath, dyspnea, loss of smell and taste, which is pretty unique, and then some diarrheal symptoms as well. So we'll talk about that. In terms of replication, so positive sense RNA virus, just kind of walking through how this virus infects susceptible cells. It's got a glycoprotein on the exterior, because if you look at that cartoon, even if you've never studied this virus before, can you tell me what that viral glycoprotein is that is responsible for binding to the host cell receptor? Spike protein, exactly. And then the host cell receptor is what? ACE2, angiotensin conversion enzyme 2. So this virus comes in contact with cells that express ACE2 on the surface. It gets endositosed in the cell, receptor-mediated endocytosis. The dropping pH in that endosome triggers conformational changes in spike protein, which cause it to fuse with that endosomal membrane and release contents of that virus out into the cytoplasm. It's an RNA virus, so it does all of its business in the cytoplasm there. This positive sense virus can go, it's in the right orientation to be recognized by host cell ribosomes and be translated directly into early protein products. One of those key early protein products is its own RDRP, this replicase here, which can in turn synthesize antigenomic negative sense templates from that genomic strand. And then from this negative sense transcript, or negative sense strand, antigenome that comes off of that can be used to transcribe all these other viral proteins. So these would be in a positive sense orientation, but notice they're not going to be involved in replication. Their sole job is to be translated at that point. So these transcripts will go off into the endoplasmic reticulum, into the ergic, the endoplasmic reticulum, Golgi intermediate compartment, and the Golgi itself. And they will be modified, glycosylated as needed, and processed. When all of that happens, you will have assembly occurring of these viral proteins, as well as those genomic plus-stranded copies of the genome into these virus particles, and those virus particles will get released from those cells. That's the infectious process. I mentioned that ACE2 is the primary receptor, and there's a lot of different tissue types throughout the body that express ACE2 that make those tissues ultimately susceptible to COVID infection, COVID infection. There's a co-receptor called neuropilin-1, which I think you will probably talk about at some point in A&P, if that rings a bell. And if it doesn't, it will at some point. But neuropilin-1, NRP1, acts as a co-receptor, which kind of greases the skid if it's co-expressed on the same susceptible cell. If it's not there, this virus can still get into the cell. This just makes it easier, that's all. And this is also involved in pain, silence and pain signaling. So that is thought to contribute to people walking around with COVID-2 infections longer than they normally would because they're not sensing that they're infected and that there's a problem yet. So that has some significance there. Once those viruses get into the cell, they will immediately start silencing interferon response from the cells. That prevents those cells from committing apoptosis, undergoing apoptosis. And that propagates the infection, allows for unchecked viral replication. Not quite unchecked, the immune system still kills a number of infected cells, but it helps those viruses propagate more. We'll go through the pathology extensively in the next couple slides, but a lot of the significant pathology when you have moderate or severe COVID infections relates to damage due to blood vessels and this bradykinin storm that you get. So bradykinin, unlike neuropilin-1, is associated with pain receptors and making you feel pretty awful. So once you have a bradykinin storm, a lot of the malaise is due to this, and a lot of the pathology as well, causing vessels to leak and things like that, edema in those tissues. This is kind of a busy little infographic, but it's worth studying in detail because I think it does a really good job of explaining what is happening to your alveoli when you get infected with COVID-2. So we'll go through this in some detail, and it dovetails nicely with where you are in A&P as well. So normally when you're talking about the alveoli, the cells that line there, that make up the alveoli, are type 1 or type 2 cells, pneumocytes. And type 1 cells are the ones that are really, really thin, and they're responsible for allowing oxygen to be transferred from these capillaries into the air sacs themselves. The type 2 alveolar cells, pneumocytes, those are responsible for mucus, maintaining that surfactant mucus layer in the air sac, and that allows it to keep its shape. So this is a normal, healthy air sac. You can see the gas exchange is happening, carbon dioxide out, oxygen in, the barrier function is maintained. There's not fluid leakage into the air sac itself, it's just air. And the air sac is very close to the capillaries, so air exchange is very efficient in a healthy alveoli like that. Or I guess it would be healthy alveolus. When you have, when you start inhaling COVID-2 and it gets down into your lungs, they'll start infecting primarily type 2 alveolar cells first. So they'll be the first to get infected. These can be lytic infections, so you'll start getting actual primary damage to those surfactant expressing type 2 pneumocytes. But the first pathology you get is related to the host immune response. Those infected cells are going to start releasing cytokines, so the same old players we always talk about, IL-1, IL-6, IL-8, tumor necrosis factor. You get recruitment of other innate immune cells like neutrophils, which do a lot of damage. Those start coming in. So even with mild COVID-2 infections, at that point you're starting to get some symptoms. And a lot of those symptoms we related to the immunopathology, the recruitment of these immune cells into that area. When we have moderate infections, at this point, we have a lot of extensive damage done to those type 2 cells. So we've talked about the function of what those type 2 cells are doing. What would happen to the functionality of an air sac if you were to destroy the type 2 function, its contribution? It would start collapsing, yeah. So that's what we see with moderate COVID. And if you look at the symptoms, the text is really small. I tried to break that up a little bit. But at this point with moderate COVID, you will have some fluid starting to leak into those air sacs because of the diathesis of all these immune cells into that area to try and kill off those infected cells. So you'll have some fluid that's accumulating. That fluid that builds in this interstitial space there between the air sac and the capillary, that increases the distance that oxygen and other gases have to go to be exchanged. So that is going to start causing respiratory issues. The patient would be able to feel, they would have shortness of breath at that time. And then when you have severe COVID infections at that point, those type 2 alveolar cells are destroyed. So those air sacs are essentially, the structural integrity is shot. They are filled with fluid. The oxygen and gas exchange capacity of these cells is really shot. So at this point, gas exchange is extremely impacted. Breathing becomes extremely difficult. This would be, if you look at the corresponding symptoms of the text, this is when people can get things like acute respiratory distress syndrome. If it gets really bad, the protein and other like cellular debris and breakdown products can get into circulation, go into the blood, and you can get septic responses like SIRS, septic inflammatory response syndrome. That can be fatal. So yeah, if you ever wonder how people actually die of COVID, it's when things get really severe like this, or they get secondary infections as well. But that's when things can get potentially fatal. Most people will have, mild COVID cases, moderate COVID cases, even asymptomatic COVID cases. But you've probably heard of this phenomenon of long COVID, very long sequela that occurs after you've cleared the virus itself. There's a whole range of different common manifestations that occur after you have cleared an infection. It's still pretty mysterious. There are some things that we think might be contributing to people who develop these sequelae and get long COVID, but we don't have a good grasp on which of these factors is predominant and which are unlikely. I had a 71 alpha BOLIC student come through last cycle, and he did his dissertation on COVID-19 sequelae. Really interesting talking to him, but he had this whole theory on what caused it. But it's not like it was a definitive or conclusive dissertation. Okay, and then in terms of kind of conceptualizing SARS-CoV-2 and its severity and its transmissibility, this is kind of a helpful chart for us to look at to understand it. It relates the severity, which is on the x-axis of this virus, and the transmissibility of it, which is on the y-axis, with some other well-known viral diseases. So SARS-CoV-2 has gone through 776 million people worldwide. Those are more or less confirmed cases. In the US, we've had over 100 million cases. And this data is 4 months old, by the way. I haven't updated it for this semester, so higher numbers than that even. But the point is, it's gone through a lot of people, right? With each person that this virus goes through, there are billions of replication events. With each replication event, there is possibility for mutations and errors. So when you start doing the math, it's astronomically high on the number of mutations that occur in this RNA virus. That's not untrue of these other viruses. Like you have some influenza viruses, these are also negative sense RNA viruses, or just RNA viruses writ large. Chickenpox, that's a DNA virus. Measles, that's an RNA virus. It's extremely infectious. So comparing it to these, it kind of just depends at what point in the pandemic we're talking about with SARS-CoV-2. Some of these mutations make it more transmissible, some of them make it more severe. It just depends. But we have been able to, in the course of just 4 or 5 years we've had COVID-2, characterize these changes that change the phenotype of this virus, that make it more transmissible or more severe. Remember when Alpha first happened, and then that gave way to Delta, and then Omicron, you know, those were serious changes that happened that affected the phenotype of this virus. Pretty interesting. In terms of kind of getting our head around some of these, like how the scientific community has categorized these changes, we have variants of concern. These are mutations that alter the phenotype of the virus, so something that changes its binding affinity to ACE2 receptor, something like that. Something that makes the vaccine less effective, because there is selective pressure on these viruses to be resistant to the vaccine or resistant to any of the treatments that have been developed against this virus. In terms of naming, the WHO has assigned these group designations to different phenotypes of COVID. So we have Alpha, Delta. We're still on Omicron right now. I don't know if we'll ever get past Omicron. And then for more of the bioinformatics community, we have a Pango lineage nomenclature system. You've heard of like B117, things like that, XB11. That's the Pango lineage system. And basically that's just categorizing these viruses on the basis of their familial relationships to each other. So like B117 is derived from B11, and that's how they're determined. Very hard to keep track of those, but it's used to establish those relationships. And all of that, of course, is important for staying on top of vaccine development, treatments. With vaccines, having talked about influenza with you guys and the amount of effort that goes into formulating influenza vaccines, hopefully you can kind of appreciate that we have the same challenges when we talk about vaccine design and updates for COVID-2 as well. We have to constantly stay on top of mutations that are affecting coronavirus. And then lastly, I'll put you guys on break after this. Just one example of a variant of concern that was extremely impactful is this one that happened with spike protein. A lot of the more significant mutations are in spike protein, and they oftentimes are associated with changes in transmissibility. But this one was a single amino acid mutation where we had an aspartic acid be mutated into a glycine, so that's a D614 glycine at position 614 in the amino acid sequence of spike protein. And because of that, it had a whole bunch of implications. It was more transmissible, more severe, it made it less susceptible to treatments, just one mutation difference in that spike protein. All right, let's take a 10-minute break, and we'll start back up at 11.
How I see it. if I can survive, maybe that's what you're talking about. Maybe it's just
Alright guys. Let's start again. Before we start talking about herpes viruses, which is the next section, I'll skip back, if you wanna go back a couple slides to this severity transmissibility chart real quick. It's a good lead-in for herpes viruses. We were talking about, we briefly mentioned measles, because measles is on this chart. If you were to interpret what this chart is telling you about the severity of measles infections, what would you say? About the severity on the x-axis. Yeah, maybe not super severe as an infection, right? What about the transmissibility though? Like off the charts, super high transmissibility. And it is indeed one of the most infectious viruses we have, one of the most transmissible viruses. Actually, we have the vaccine, but what do you think this R means? Like if I were to verbally say R naught 12 to 18? Yeah, and that would be vulnerable people. So in an unvaccinated population, you'd expect one infected person to infect 12 to 18 people. Okay. So before we had the vaccine, you can imagine like a lot of people got measles. If we were to plot out something like, I don't know, Ebola, we haven't talked about Ebola yet, but we all know a little bit about that virus. Which quadrant do you think Ebola would be in? Bottom right, yeah, so maybe, bottom right. So severity is high or low? Tends to be pretty high, considered to be one of the most severe virulent viruses. And then transmissibility, it's certainly not airborne. It's usually transmitted by contact with bodily fluids that are infected. So not super easy to transmit. The other virus I want to kind of orient you to, actually real quick, common cold viruses, notice those are among the least severe and not super transmissible either. But then chickenpox, this is one I want to talk about because it is a herpes virus, and we're going to be talking about it soon. It's in that lower left quadrant, not super severe, but it does cause some severe disease. And then in terms of transmissibility, from what I know about this virus, it probably should be a little bit higher in transmissibility. So you do shed it from a lot of places, but it's easy to shed chickenpox to vulnerable people. So we'll start off with this intro slide for herpes viruses, but very soon we'll be talking about chickenpox when we talk about HHV3 varicella zoster virus. So as a family of viruses, herpes viruses are DNA viruses. They have really big genomes that make a lot of viral proteins in the viral world, so it's not a lot for other pathogens, but they do make a lot of, they encode for a lot of different proteins, viral proteins. sophisticated proteins, a lot of control over the host cell, a lot of control over the immune response that allows them to establish characteristic infections, a broad range. They can have lytic infections, they can be persistent, and they can cause latent diseases, which is kind of what they're famous for. If you know only one thing about herpes viruses, what do you know about them? Once you get them, you don't get rid of them, you're stuck with them, they're there forever. And that's because they established latency, they're able to do that. DNA viruses establishing latency. They are numbered 1 through 8 with different associations for HBs8. They're all human-specific viruses, so HH. These are not zoonotic diseases, these are maintained solely in the human population. And they're extremely successful in circulating in the human population because of the fact that they can toggle between lytic, persistent, and latent infections. It allows them to exist long-term in the population. And there really isn't a geographic distribution that's associated with herpes viruses. They're all over the world, ubiquitous, with the exception of Kaposi sarcoma herpes virus, which we'll talk about at the end of the lecture. We'll just go in sequence, starting with HSV1 and HSV2. This is, the S is for simplex, herpes simplex virus. These are very common infections. These are neurotropic viruses, and they establish their latency in dorsal root ganglia. So, in terms of the infections, you may be familiar with this, but HSV1 and HSV2 have distinctions on which types of tissues, which parts of the body they tend to infect. HSV1 infections tend to cause more of these upper body infections, particularly this gingivostomatitis, which are cold sores around the mouth. That's what it's mostly associated with. HSV2 is the one that's regarded mostly as an STI, sexual transmission, getting these crops of little lesions in the genital region. But it's good to be familiar with the fact that these viruses can cause a bunch of other problems as well throughout the body, and they're also not mutually exclusive to those specific parts. So HSV2, the STI, can also cause cold sores around the mouth, and HSV1 can also cause genital ulcers. They're just a slight tropism that they prefer, but it doesn't mean they can't cause these symptoms or these problems interchangeably as well. So yeah, the common cold sores, this is the gingivostomatitis. It can also cause pharyngitis, get keratoconjunctivitis. Herpetic whitlow, anyone know what herpetic whitlow is? Yeah, commonly associated with these vesicles or ulcers forming on the fingers, where you have come into contact with cutaneous break in the skin, you come into contact with this virus, and you get these lesions on your fingers oftentimes, but you can theoretically get it anywhere in the body. I think I have a picture, no, I don't have a picture of what that looks like, but it's just like an ulcer on the finger. Both of these viruses, HSV1 and HSV2, can cross the blood-brain barrier and cause potentially life-threatening encephalitis or meningitis encephalitis with HSV2. When they do that, HSV2 is the more dangerous of the two. It causes more deaths, more severe disease. So that's something to know. With congenital infections, this is another thing that's oftentimes overlooked as well. This is oftentimes transmitted to babies during delivery when mothers are infected, oftentimes with HSV2, the STI form. The baby picks up the virus, starts replicating in the baby, and then a couple weeks later you can get almost like a septic type presentation with infants. Sometimes they can get really severe encephalitis and meningitis as well. And if they do survive, because infants are at such a vulnerable point in their life, they can develop long-term neurologic sequelae as well, which can be really damaging. I remember when I was at Madigan, I was working in the molecular diagnostics section. We were running a lot of PCRs. We used to get a lot of like CSF samples for rule-outs on meningitis and encephalitis. We got a lot of cases from neonates. I remember one in particular. Within 2 weeks of him being born, he started to develop signs and symptoms of like disseminated herpes simplex disease and encephalitis, like really, really severe. He was coding and his parents were taking him to the ER, and they would do a lumbar puncture, on this newborn, sent us his CSF, we would always detect HSV2. They would put him on a course of like one of the cyclovirs, acyclovir, valacyclovir, I don't remember which one. And then he would be fine for a little while, and then he would get sick again, and then they'd do something to tweak his medications again, and he'd get sick again. And this poor baby, he was always getting tapped. I mean, extremely painful, but he was always getting tapped, he was always coding, and no matter what they did with his medications, he kept getting recurrent infections of HSV, so like lytic infections caused him a lot of problems. He eventually died at 8 months old, but it's a terrible, terrible experience. And we sequenced the virus that we got out of his child, and he had like a resistant polymerase, so the drugs that they were putting him on weren't having an effect, or they weren't having as much of an effect as what we hoped. But yeah, it was like a terrible case, and I'll always remember that one. So yeah, all that to say is like you kind of associate herpes simplex with these cold sores on the mouth and genital lesions with HSV2, but don't forget about some of those more severe presentations too that's associated with it. In terms of clinical significance, here's a picture of what those cold sores look like. Very, very common. You can get initial presentation oftentimes is fairly severe. These can be painful lesions that occur, but they don't last very long. Usually they'll heal within 8 to 10 days. Normal for immunocompetent people is a couple flare-ups, like 1 to 3 flare-ups a year, and tends to get lesser as you age, so fewer and fewer flare-ups or reactivations of these cold sores when you're talking about the classic HSV1 presentation. What happens when you have an active infection is you have viral replication in the epithelial cells. So right there at the mouth, for example, these, and then maybe the mucosa as well. And you get damage, some pathology to those cells. That's what causes the cold cells, or the cold sores. And then the viruses will kind of spontaneously go into this latent phase. So they'll travel retrograde to the trigeminal ganglia in the face, so right here, and they will stay latent until the next reactivation. So that could be months and years later down the road. Ditto with HSV2, when you have the genital presentation, genital ulcerations, this is what it looks like when you have an active case in a female and in a male. When it's actually visible, not always painful either, so you can get transmission from people who aren't aware that they have it. But importantly, you're only shedding virus during these reactivations. When it's latent, you are not transmitting virus. The virus is located in those dorsal ganglia. Yes, sir. Cell-mediated immunity. Yeah. So, for a viral infection, this CMI response, cell-mediated immune response, is really important for keeping this in check. People who are immunocompromised are particularly vulnerable, and they have a harder time controlling those flare-ups. They will probably be on antiviral meds a lot because they just need to control the frequency and severity of those flare-ups. But in terms of other symptoms, this is usually a localized infection. It doesn't get disseminated. You're usually just getting it along where those neurons are serving. So whatever areas of the skin where those neurons are serving is where you get those flare-ups. They can be a nuisance. You can transmit them, like I said, and that's a major concern, is like unwitting transmission to other people. With HSV1, this is extremely common. Like most of us in this room probably have HSV1 latent, hiding out in our trigeminal ganglia. We can track that as kids. We get it because we're sharing beverages, for example, and virus is being shed from those ulcers, those cold sores. So we spread it around, perfectly fine. Most of us never have flare-ups at all. And that does also confer some cross-protection should you get HSV2 later in life. So if you get HSV1 as a kid, and then let's say you're 20 years old and have sexual transmission for HSV2, it tends to be less severe because you have some protection against that virus. So silver lining to that cloud. I'm just saying, like, why not be an optimist? In terms of diagnostics, oftentimes this is something that's pretty easy to diagnose with somebody, early 20s, late teens, whatever, comes in with these genital lesions. We have a lot of diagnostics for it, but PCR is a big workhorse. So we don't require that testing most of the time, but when you really want to make sure to put a patient on one of these antivirals like acyclovir, famously, which is a major herpes virus medication, would be when you're talking about somebody who is really susceptible, like a newborn. You really don't want to get encephalitis. We can also do viral culture. We can scrape the vesicles themselves. That fluid in the vesicles would be packed with virus, super transmissible. If you're doing a cell culture, the CPE, the cytopathic effects, are characteristic. You get these massive syncytia that form. Syncytia meaning fused cells that causes them to fuse together, giant cells like that. We can also do immunofluorescence as well. Varicella zoster virus. This is a twofer. You get two different presentations with one virus. The more well-known one is probably chickenpox, which is the varicella component of this virus. We do have a vaccine for this. We've had a vaccine, that's at the bottom of the slide there, if you skip down to Varivax. We've had some sort of vaccine against varicella since the 90s. So if you were born before 1995, let's say, you probably got this au naturel. Anybody, you got it twice?
Chickenpox virus.
Oh, chickenpox parties, yeah.
Well, like, getting together, that's what they did last.
Yeah, okay, so your parents took you to a chickenpox party. That was a commonly done thing back in the 80s and probably before then too. Yeah, so parents would take their infected, rash-presenting children, put them, together, this highly, pretty infectious transmissible virus that is shed from those, shed from multiple places, but those vesicles are shedding a lot of virus, so it's super, super infectious. And then also through the saliva as well, so, and then also through airborne release as well. So super infectious. Parents would take their kids to these parties, and because it's considered to not be that severe a disease, that was commonly done until the vaccine was offered, like I said, in the 90s. A lot of people still prefer to do things au naturel without a vaccine, but the reason why that's not a good idea is because with the vaccine, you will not have complications. Without the vaccine, if you take a kid to a chickenpox party or expose them some other way, chances are they're going to be just fine. It's a self-resolving infection, but there are some serious complications. This form of pneumonia called a varicella pneumonia, pretty serious. You can get encephalitis caused by this virus and liver damage as well. So those are the strongest reasons we have for not doing that anymore, since we have Varivax, this live attenuated virus vaccine that has been approved for kids over the age of 1. Okay, so you get your rash, which usually, rash appears on the scalp, on the face, on the trunk. Doesn't cause a lot of symptoms. You might get a little bit of a fever. It's itchy. If you remember having this virus infection yourself, it is super itchy and unpleasant. But when it resolves, you're generally good to go, right? Problem is, this is a latent virus, so it is going to travel retrograde along these axons to dorsal ganglia. So those are the ganglia that are right around the spinal cord. And whatever area of the skin you have that rash, they're going to go to the dorsal ganglia that serves that part of the skin. And there they sit for a long, long time. Assuming you're immunocompetent, your CMI, your cell-limited immunity, is going to keep those viruses in check and latent for a long time. However, 30% of individuals will eventually have a reactivation of that virus, the varicella zoster virus. And when it reactivates, the presentation is called zoster or shingles. Zoster means belt, and that tells you something about the presentation and how different it is than the primary infection with chickenpox. But chickenpox, that rash is all over the body, but when you get reactivation, you get zoster. The virus is going to be traveling along the dermatome, so you get these banded presentations of vesicles that look similar to the primary vesicles of chickenpox, except for where they're presenting on the skin. But then it's the same deal, you have an actively replicating lytic virus that's causing damage. So you can see like this dermatome that's infected with shingles, that band around this person, it's a common area to get reactivation. That virus is actively replicating, it is infectious and transmissible to other people who don't have immunity, either natural or artificial immunity. And if they are shedding virus to a susceptible person, that virus is going to cause chickenpox in that person. Let me ask you guys a question. Let's say you have a person who has never been vaccinated with Varavax and they were never exposed at all somehow as a kid. And then they're 30 years old and they come in contact with somebody who either has chickenpox or shingles, an active lytic infection. Can they still get chickenpox? Absolutely, yes. We associate chickenpox with kids as a pediatric disease, it's one of the major childhood rashes, but adults can certainly get it, like primary chickenpox. So that would be the presentation there. This should resolve as well, assuming your immune system can get it under control, you get that reactivation. But it's never gonna go away, like any of the herpes viruses, they never go away. So at best, it's just going to retreat back into the dorsal ganglia again. The main problem that we are concerned about with zoster though is one of these sequelae called post-herpetic neuralgia, which is where you get really serious pain associated with those areas that are infected. Anywhere from tingling pain to stabbing, shooting pain throughout that area. It can be debilitating, it can last for weeks or months. You can get other complications as well, but this is one of the reasons why we want to avoid people getting reactivation and getting zoster or shingles. So we do have a vaccine that is available called Shingrix. It replaces an earlier one, I forget the name of the earlier one, but this, I think this is the most recent one. It's a recombinant subunit vaccine, 2 doses, and it is approved for people over the age of 50. So that's kind of around the time where your immune system might be in slow, gentle, gradual decline. But you would definitely want to get that if you could get that vaccine to prevent things like sequela from shingles presentation. My dad got shingles, and I remember that. I don't know if you guys had any or known anyone who'd gotten shingles, but it affected him right along his eyes. And he had vesicles on his eyes, and his eyes were tearing up and very painful, and it was like that for weeks. So, yes, sir.
I guess what's the difference with shingles versus or the Shingrix versus Varavax, since they're derivative from the same virus, right?
Yeah. Well, one is just what they're composed of. Like the Varavax is a live virus vaccine, and this is a subunit vaccine. But in terms of the difference, I don't know. I'll get back to you on that. In terms of what the goals are vaccinating those age groups. Do you know?
No, I
Oh, you have a question? Okay. Does I'll get back to you in just a second. Does anybody know the goals between Varavax and Shingrix? Okay, I'll get back to you on that. Yes, sir.
Man, does it damage the nerve? I remember my cousin, he got shingles and he got some Bell's palsy afterwards. I don't know if that was related to damage and inflammation.
It might be. It might be related to that neuralgia that is common with this virus. Yeah, some nerve damage there. And I don't know. I'm more familiar with the pathology of the lytic infection when it's damaging blood vessels and skin cells. But that neuralgia is kind of a mysterious pathology of the pathogens. But yeah.
So I can clarify again, so transmission for zoster is just viruses being shed from those blisters, it's not an aerosolized way chickenpox.
Yeah, I think it's primarily shed through those blisters, which have that liquid in them that can be transmissible. But in terms of how you get zoster, you can't get zoster through primary transmission. This is a reactivation of the enzymes.
I've heard it's called herpes zoster before. Is that
Yeah.
not?
Same, but it goes by other names, but if you're saying herpes zoster, that's talking about one of those two presentations. The virus itself is VZV, varicella zoster virus. also known as HHV3, human herpes virus 3, going by that numbered system. But yeah, again, like varicella corresponds to chickenpox, zoster corresponds to shingles. But the same virus, it's always going to be the same virus. Two different presentations. Okay, this virus is HHV4. It's called Epstein-Barr virus. EBV, famous for causing infectious mononucleosis, IM or mono, also known as the kissing disease. The classic case is usually like late teens or teenage years. It's associated, it gets the moniker kissing disease because it's transmitted through kissing, but swapping saliva, sharing beverages, things like that. Not an airborne virus, but since you're shedding it in virus or in your saliva, it can be transmitted that way. A lot of us probably have antibodies to this, meaning we've probably been exposed to it. Most normal healthy people who have Epstein-Barr never know they have Epstein-Barr virus. But in the kids who get mono, they're perfectly healthy. It's just that virus has managed to infect, the cells in your lymph nodes basically and cause these symptoms, which you kind of can associate with mono. You get a fever, you get sore throat, and you get enlarged lymph nodes. That's the triad associated with mono. Also, you get a lot of fatigue. I don't know if any of you have ever had mono, but it wipes you out. It lays you out. You will be, if you're like 15 years old, you're gonna be missing school probably. And when you do, you're gonna be missing a lot of school because it's a long-term thing. Like you can be out for weeks with this. So extreme fatigue, you get hepatosplenomegaly, enlarged liver and spleen. Takes a while for this virus to replicate and get symptoms at all, if it does cause symptoms. And then you resolve the infection. Most of us, we resolve the infection. Where it establishes latency is important though. So it establishes latency in B cells. And that's important for this next bullet with its oncogenic association. This was the first virus that had really strong evidence linking it to a cancer or malignancy. And it was linked to Burkitt lymphoma, which is a uncontrolled proliferative disease of B cells, lymphocytes. So when this establishes latency in B cells, just based on the biology of B cells, they tend to be good at proliferating, as we've talked about in the past. So you get infections, those infections become latent, and a small percentage of people can get Burkitt lymphoma, Hodgkin lymphoma, and nasopharyngeal carcinomas down the road. One important thing, when it does establish latency in B cells and it starts through this unusual course, like this carcinogenic, oncogenic potential, one thing it does is cause like an uncontrolled production of antibodies in these B cells that are infected with it. So you get a lot of IgM, you get a lot of IgG, and you get a lot of IgA that's produced. These are called heterophile antibodies. And this is such a strong association, we can actually use those heterophile antibodies to diagnose this disease. So that's a heterophile antibody test. It's based on the fact that you have multiple subclasses of antibodies being produced by these infected B cells. And the test is mostly centered around IgM. The IgM will visibly agglutinate when you mix it with serum from one of these animal species. One stat about this disease before we moved on is about 90% of adults are seropositive to EBV. So in this room of 65 people, high order, like at the high end, if around 50, 80, 59 of you are infected with latent EBV, it's causing you no problem at all, and it probably never will. It's just a statistical thing that a lot of us are seropositive for it. Similarly with CMV, 69 to 90% of the population has antibodies by adulthood. A lot of us pick up our exposure to CMV, which is HHV5, if you're keeping count, in childhood. So you pick it up in childhood. Most of us never have any issues or problems with this virus, but we can shed it in low levels, particularly if it's in a persistent infection in these cells. So we'll shed it from saliva, blood, tissue, it could be in breast milk, a lot of different body secretions. When it's lytically infecting viruses during active replication, it'll infect macrophages, epithelial cells, and other cell types, but it established latency in hematopoietic stem cells and monocytes, so that's important as well. This picture up to the right is showing some cytopathology associated with CMV. This is called an owl's eye pathology, this inclusion body. It's just because a lot of when this virus is replicating, it forms a lot of junk, non-productive, non-viable virus particles, and they get basically tossed into these inclusion bodies in the cell. So the owl eye is like a giant garbage pile of viral components that have failed to assemble and produce functional viruses, functional viable viruses. Like Epstein-Barr virus, CMV also can cause infectious mononucleosis. So about 8%, so much smaller percentage of mono is caused by CMV. The symptoms are basically the same. You still get a little bit of, the fever, the sore throat, the lymphadenopathy. The difference would be you don't see that pattern of heterophile antibodies being produced by B cells. That's because they infect a different type of cell, but they still cause mono. Congenital infections are the major concern with CMV. We have the most common cause of intrauterine viral infections and congenital abnormalities in the US. So that's really important. I'm going to start abbreviating most common as MC just to save some space. But this is a major issue with CMV. We have cytomegaloid infusion disease that happens when kids pick up cytomegaloid infusion disease. That is associated with damage to the liver, the spleen, and the nervous system. The stats are at the bottom here, but this can cause a range of different problems. Stillborn babies is one of them. And if they survive, some of these problems like the hearing loss, the mental retardation, the eye damage, some of that is not evident until kids get to be 4 or 5 years old, and then parents will recognize that they have some sort of developmental delays or hearing problems, and they'll eventually get tested and hopefully find that the etiology is CMV. But CMV is a major etiology for some of these problems with early childhood. With immunocompromised people, CMV is one of those opportunistic infections to be familiar with as well. In particular, its ability to cause pneumonia and CMV retinitis. This is causing blindness. And getting towards the end of the herpes viruses, I split this up a little bit. This should be, human herpes viruses 6 and 7 on this slide, and then 8 should be on the next slide. 6A is associated with multiple sclerosis and Alzheimer's disease, but there's not a lot known about those associations, so they're not well characterized yet. Much better studied and understood is HHV 6B and HHV 7. And their association with a very common childhood rash, another common childhood rash. This is called roseola. It is not a very severe infection most of the time, self-limiting childhood disease. It affects a large percentage of babies. There's no vaccine for this, so and some children will have a varying amount of a rash here. This baby in this picture, you can see a bit of a rash, but I think that's a smile. I don't know, I can't read infant expressions very well. He seems to be doing well and enjoying his first childhood rash. First of need. I don't know, how many parents are in the room, just out of curiosity? Good number, a huge number of parents. You guys have, any of your kids have childhood rashes like this?
My oldest had 6.
Oh, did he?
He's like 18 months old.
How did, were they very sick or pretty much just the rash?
The rest freaked me out. So I was like, oh, where did this come from? But then
Okay, so freaked, but no like fever or anything, right?
maybe mild.
Okay. But it freaked you out enough to go get diagnosed, and you got definitively diagnosed with HHV6B. Okay, for a second.
It was the initial presentation, if I'm not mistaken, it's like it's mutual. It started
Yeah, okay. So he said that the presentation keyword was centrifugal, with an F, centrifugal, starting from the center or from the top and then going outward like that. That's characteristic for a lot of rashes, the way they develop. And definitely true for this roseola presentation of the rash. This should be a pretty impressive stat. 90% of people are seropositive by the age of 3. So this virus does really well. Again, when these kids, when we as people get exposed to this as babies, and you get this rash, when it establishes latent infection, it usually does not cause a problem at all later in life. So for that reason, there's not a lot of attention or focus on it. One bullet here with, again, immunosuppressed people who are transplant patients, that has been associated with organ rejection. Like the organs that they receive have HHV6B in them. So screening is probably important in those instances. Okay. And then lastly, this is the last virus we'll cover today, Kaposi sarcoma herpes virus, KHSV or HHV8. This is another oncogenic virus like like EBV that we talked about that had the association with lymphomas. With this is more associated with a skin malignancy. So sarcomas affect the skin, mucous membranes, and internal organs. Anybody seen that movie Philadelphia with Tom Hanks? Couple people? Okay. If you haven't, this is a scene from Philadelphia where Tom Hanks is taking a stand and Denzel Washington is his lawyer, and he's talking to him about the presentations. He is, at this point, clinically has AIDS, so he has some opportunistic infections. And one of those opportunistic infections that's associated heavily with AIDS is KHSV. So this presentation, this is right in the movie, he has those classic brownish, purplish lesions all over the torso. They can be all over the body, but the same lesions can affect internal organs as well, so it's all over the place. Very low prevalence of this virus in the healthy population, so that implies that it's not that transmissible. And usually, most cases occur where the HIV prevalence is high, so there's indication, even though we don't have a lot of good evidence about this, that transmission is oftentimes sexual transmission of this virus. I mentioned that there was a geographic bent to this virus, and that's its association with causing skin cancers in sub-Saharan Africa, where it is like the most common MC, I should have put that there, MC cause of cancer in sub-Saharan Africa. That tops ovarian cancer, which is really saying something. This virus is detected in over 90% of people who have Kaposi sarcoma. So a very, very strong link in its ability as a DNA virus to cause cancer, particularly this type of cancer. Any questions about the herpes viruses? Okay. I will see you guys tomorrow probably. I got tight for staff duty tonight, so I think I'll be in the building, all night. So let me know if you have any questions.